Hi guys, we're almost done. Module 6 covers lines and devices. After this module you have one more on pediatrics and then we're through. So we're going to take a few minutes and we'll talk about how to deal with patients with special healthcare needs through different devices that we will carry on the truck. So I'm going to give you a second to review these objectives. Feel free to pause the video if you need to. So central venous catheters, typically the tips are going to terminate in one of three places, either the superior vena cava, inferior vena cava, or the right atrium of the heart. But the peripheral CV caths are inserted through a peripheral vein and they are advanced into that position where they terminate there. So peripheral catheters, typically the insertion sites for peripheral catheters are at the basilic vein, whereas your central caths, they look more at the internal jugular, subclavian vein, or even the femoral vein. Now there are several types of CV catheters. Some are non-tunneled, tunneled. You can have your PICC lines or the implanted vascular access ports. And the non-tunneled catheters, this is what they look like. They're utilized for short-term use only, and they have to be changed out every 3 to 7 days. So they are not appropriate for long-term therapy. The ones that are tunneled are actually designed for long-term use, and they're made of silicone. And it's the reason why they're used. The silicone ones are used is because they are less likely to form any blood clots or thrombus, and it's less irritating to the vein. It's cuffed at the exit site, and that helps to encourage tissue growth, and it helps to anchor the catheter and keep bacteria out. The other thing about the tunneled catheters, they're more common in home and EMS patients, so they're seen with patients that have systemic compromise that require routine medications. Whereas the PICC lines, which are also known as long line catheters, they can be anywhere from 20 to 24 inches in length, and they can be anywhere from 14 gauge to 22 gauge in diameter. They can either be single or double lumen. They are typically inserted proximal to the antecubital fossa, the AC, and the line is advanced through the vessel and into the central circulation. Out of all the ones that we see in the healthcare setting, the PICC lines are most commonly encountered. Do not use a tuberculin syringe or a 3 cc syringe to administer drugs or flush through a PICC line. Remember that the pressures, the increase in that pressure, that high pressure, is too great and it can actually rupture the line. So this would be an example of the PICC line, and you can kind of get an idea of how that would be inserted and how it works. Now, there are 6 steps to flush out a CV catheter. First and foremost, you have to clean the cap with alcohol and allow the cap time to dry. And then you're going to inject the flush solution, the saline solution, and make sure you maintain positive pressure on the syringe by keeping your thumb on the plunger, because it will hit because it is a central line, it will have enough pressure to push back. But you want to engage the clamp on the CV line, withdraw the syringe. Sorry guys, I had to pause the video. Had a coughing fit. But if the line flushes easily, then you can continue your IV infusion, and if you need to change a heparin lock adapter, then you have to close the clamp and make sure you clean the connection site like we did before, flush the new adapter, and the patient needs to Valsalva during the adapter change. So we want them to vagal down, if you will. If it's an implanted vascular access port or a Mediport, this is a long-term catheter that's actually implanted under the skin, and it's on the anterior chest wall, and it does require reheparinization once a month. But and what makes this good is there's less risk of infection, because after the incision heals, the patient can resume daily activities, and you would just monitor the infusions through a VAP. And this is a good pictorial representation to kind of show you what that Mediport actually looks like and the particular needle that's needed in order to access that port. We're going to take a few minutes and talk about the problems that can be encountered with different lines and how we can adjust to those problems and what interventions are needed. So whether it's a CV line, a VAP, or a PICC line, all forms of central lines should be assessed for patency prior to transfer by the C3IFT medic. You want to ensure that those are adequately placed and that there's no issues with them. That way the responsibility stays on the sending facility. It's similar to a peripheral IV. You want to assess the insertion site, look at the medications, make sure that those and the fluids are infusing properly. And if a line is not infusing, we want to troubleshoot the pump and the line first. If the problem is in the access device, we want to seek alternative methods of infusion or consider a CCT team to transport this patient in order to maintain those difficult lines. If you have a case where fluids won't infuse, the causes could be a closed clamp, kinked or displaced catheter, or clot formation in the catheter. But your management is to make sure that you check all the devices and all the clamps, reposition your patient, and attempt to try to aspirate blood back, but never force a flush. If you try to attempt the flush, then you never want to force it. If you're meeting resistance, leave it alone. If you have leaking of fluids, the causes are most commonly either a torn or cracked catheter, or the catheter has become displaced and you see lymph and serous fluid that's leaking at the insertion site. The primary thing you want to do is assess the patient's status and attempt to find that source of the leak. And if the catheter is cracked or torn, clamp the line. You want to use non-serrated hemostats if it's an emergency setting. And as always, remember, you're not wanting to force flush a catheter. Never attempt to straighten a kink in a stiff CV line, and never reconnect tubing that has been disconnected for whatever reason. And never use a CV line or a VAP with redness or edema at the site. Now we're going to spend a few minutes talking about some special considerations with dialysis patients and their dialysis fistulas or shunts. So with the dialysis catheters, it's typically a 2-lumen. You've got a red and a blue port. You're typically inserted into the internal jugular or subclavian veins. But in cases of emergency of a hemodialysis patient, the venous line, that blue line, can actually be accessed for direct administration of both fluids and medications. There are absolutely no restrictions on what meds can be given through this line. But you need to know that before giving fluids or meds, you always want to aspirate 3 to 5 cc's of fluid in order to remove that high concentration of heparin that's located in that line to keep it from clotting. Cath Lab Sheaths are utilized during cardiac cath, angioplasty, stent, and intra-aortic balloon pump procedures. It's typically a single lumen line. The venous sheaths can be utilized in an emergency setting. The arterial sheaths can be monitored only by the C3IFT. And when it comes to chest tubes, you want to perform the assessment on the patient and document their respiratory and perfusion status. Maintain their oxygen requirements, watch their vital signs, their pulse oximetry and cardiac rhythms. Assess the breath sounds frequently and watch the chest tube to ensure that the drainage system is working. And when you're assessing the chest tube, you want to check the size of the tube and the location. You want to make sure that it's not taped flat to the chest because we're trying to prevent a kink in the intercostal space. We want to note the color and the amount of drainage that's coming from the device, and keep drainage device in an upright position and below the level of the chest at all times. I do know an individual who placed a chest tube suction unit on the patient's chest and redrained all of the contents back into the body. So make sure you keep the drainage device upright and below the level of the chest. And monitor the water seal and suction chambers. You want to make sure that there's an appropriate level of water, and whatever orders that were given to you by the sending or maybe perhaps the receiving physician for suction requirements is what you want to maintain. And then encourage the patient periodically to cough or to try to take a deep breath, and that helps to reassess breath sounds during transport as needed, so you can do that as part of that process. They did include this picture in case you were curious as to what it looks like underneath the skin. You can actually see what that chest tube drain looks like as it's inside the chest cavity. And this is what the actual suction unit looks like, or something very similar to this. Anytime you run across an art line or an arterial line, it's minimally invasive. It's inserted into the artery instead of the vein. It's typically a radial or brachial artery, and it gives continuous blood pressure and mean arterial pressure readings. It's easy to transport, but useful in the CCT environment especially, and it can be monitored through CCT monitor, and only the line itself can be monitored by the C3. So we're only looking at the line itself. If the line is accidentally removed, make sure you hold pressure at the insertion site to discontinue the bleeding. And this is what that system would look like if it was all connected together. Now we're going to look at OG and NG tubes. Why do we consider inserting either an oro or nasal gastric tube? How do we do it, and what do we do with those tubes once they're inserted? So we're going to look at those. The steps to insertion, this is a little bit lengthy here on this slide. I'm going to give you a few minutes to read it for yourself, but essentially you want that patient to be sitting in a high Fowler's position, and you want to have them be able to swallow, hopefully, in order to get that down where it needs to go. But I'm going to let you read this for yourself. Once you've placed it, you want to check for the accuracy in your placement by using a syringe, and you want to inject about 10 to 20 cc's of air while you're listening with the stethoscope over the abdomen, and you're trying to check and see if you can hear the gurgling noises. And then once you've confirmed that, you're going to pull back on the plunger to try to aspirate the stomach contents. And if you have any questions about the insertion component, I'm going to make sure that we have a video available to you so you can see what one of those looks like. But the biggest things we have with the nasogastric tubes is the hemorrhage as a result of irritating those nasal vessels, and passage of the tube into the trachea, because they do have a persistent cough. There could be a potential for perforation of the esophagus, GI bleeding, and which we don't want to do this, but it says intracranial insertion with a severely head-injured patient. In your head-injured patients, the NG tube is contraindicated anytime you have someone with skull or facial fractures. Now, management for these items is going to depend on the reason for the insertion and what the physician has ordered. Most are ordered to intermittent or continuous low wall suction. It should be less than 20 milliliters or less to prevent damage to the gastric lining. But this shows a good picture of an NG tube as it's been inserted and passes down into the stomach. And finally, we're going to talk about Foley catheters. And Foley catheters can be managed by the C3, it can be monitored by the C3IFT, it can be measured by the basic interfacility transfer, but you want to measure the urine output and empty the drainage bag prior to departure. So we want to do that before we leave with the patient on the way to the facility. So assess for quantity and color of urine output and document that accordingly, and always keep the catheter drainage bag lower than the level of the bladder. Make sure that the Foley tubing is taped or strapped to the inner thigh, and that's to help prevent any bladder or urethral trauma in the transport environment should it get snagged and caught on something. So this is what that Foley catheter would look like as it is placed appropriately. And the Foley catheter, you know, is not expected of a C3 medic to do the insertion point, but to be able to monitor the Foley catheter as needed. However, should the event arise and the Foley catheter is not draining properly, then you have the ability to irrigate the Foley catheter. And what you will need is a bulb syringe and sterile water. So you'd want to draw up the 30 to 50 cc's of sterile water and discontinue or disconnect the drainage bag and insert the syringe into the catheter tip. You want to slowly instill all the solution, reconnect the catheter to the drainage bag, and try to release it. You want to do this or repeat as needed until the catheter is draining as it should. If you're unable to get a fluid return, put in up to one more syringe of solution, and if it still doesn't work, contact MCP. Stop what you're doing and contact MCP at that point. And this concludes the section on lines and devices. I hope this has been at least a quick refresher for you, looking at some materials that we don't deal with very often. The next section is our final section in the review, and hopefully we'll get through that pretty easily. Have a great day.